Okay, all right. So, hello everybody. Thank you for taking time and attending this conference. Initially, it was supposed to be a business of medicine conference, but due to technical reasons, I could not find my previous presentation that I was supposed to give today. So, we're gonna do a presentation on intoxications and poisoning, and I think it will be fun. It's gonna be a case-based presentation, and I'm gonna require audience participation. So, who are the fellows that are on the line besides her?
I'm here. This is Lindsay. Can you hear me?
Hi, Lindsay.
And then there's also Rip is here, Brian Park, Brendan, Daniel.
Wow, a lot of new names that I don't know. So, hello everybody. My name is Jean-Sebastien Rachoin. I'm a nephrologist and intensivist, and welcome to this conference. So, Hirsch, can you do next slide, please? Okay, so this is the latest I could find about the frequencies of intoxications in the US. Um, so most of the intoxications happen to be analgesics, followed by sedatives, hypnotic, and antipsychotics, and all the others you can see. Obviously, uh, and the hypnotics, they included the opiates. So even though we see a lot of opiates in the hospital, it actually is not the biggest cause of intoxications. Next slide. All right. So when you evaluate somebody who has an intoxication, important cues are substance and quantity, whether it was presumed or witnessed, and if there are any additional potential ingestions. And then the last time was seen normal, kind of like a stroke, and that would help you with your diagnosis, and we're going to talk about that in a second, and B, your management. Also, very important for certain intoxications like lithium or the digoxin, the chronicity is very important because a level of 3 in lithium, acutely or chronically, have very different implications. Especially when you look at a drug which is intracellular, the level is much different than one which is primarily extracellular. So you look at consciousness, pupillary size, vital signs, seizure, odor, and that could give you some clues, and then you identify the toxidrome. Next slide. All right. So these are like general things where you would classify patients in certain toxidromes. So if you see somebody who's agitated with mydriasis, you think about sympathomimetic, anticholinergic drugs. Uh, Depressed state, you think about opiates or sedatives. Meiosis, you think also about opiate or cholinergic. When it comes to odor, classically we say garlic odor is arsenic. Never seen that. Hopefully, we'll never see it. Um, Acetone, we all know about the acetone breath with alcohol, ketones, and whatnot. Bitter almond with cyanide, and they say also kerosene is for organophosphate, although I want to confess I never seen that either. Um, Next slide. Dude, that's the last slide.
Hold on, let me get it working again.
Hirsch, you had one job.
I was underqualified for it.
Dude, one job. Okay, so when you look at vital signs, when you look at temperature, blood pressure, and heart rate, patients who have tachycardia, high blood pressure, and high temperature, you think about things like amphetamines, cocaine, anticholinergic, and sympathomimetic, whereas with hypothermia, hypotension, and sedation and bradycardia, you think more of sedatives, hypnotics, antihypertensive, and narcotics. Next slide. Hirsch. Okay. All right. So, one's first question is GI decontamination. Should we do it? So, I think I remember when I was an intern, Dr. D used to give this conference, and I remember in his very nice Texan accent, he used to say, "Ipeca is dead," and we always used to laugh, right? Um, but for real, the cathartics, MSS, and gastric lavage should not be used anymore. But we can and probably should do activated charcoal if it's within 1 to 2 hours of ingestion. Probably for most intoxication is if we don't know what has been given. Doesn't work for iron, lithium, alcohol, and hydrocarbons, but as a matter of fact, it is fantastic for something like tegretol, barbiturate, theophylline, dapsone, and quinine. So if you have an intoxication with one of those, then charcoal does a great job for those, and it has to do with the enterohepatic recirculation of the substance. Next slide. Okay, so Hirsch, since you're underqualified for pushing slides, maybe you're qualified for reading a case.
Sure. A 54-year-old man with a history of depression, hypertension, hyperlipidemia was found with multiple empty pill bottles. He is bradycardia to 48, blood pressure is 88/56, respiratory rate is 18, temperature 97.8, pupils 3 millimeters and reactive. He was lethargic but arousable. Which of the following is the most appropriate initial intervention?
Okay, so what do you suspect this patient has, if you want to put it in a category?
I'm worried about beta blocker or calcium channel blocker toxicity.
Very good. So what would be, so he's hypotensive, bradycardic, and will obviously did not give you the option of starting a pressor. That would be too easy, right? What would be the most appropriate initial intervention?
A.
Okay. All right, go next slide.
Okay.
Okay, very good. Good job, Hirsch. So you qualified to answer a question. That's good, man. That's good.
Nice.
All right, so let's go to the next slide, please. All right, so when you see somebody who has bradycardia, you have to think of things like beta blockers, calcium channel blockers, clonidine, barbiturates. I don't know why anybody would want to intoxicate on pyridostigmine, but sure. And then things such as hypnotics, sedatives, organophosphate. Next slide. So, whenever you have a beta blocker or calcium channel blocker overdose, you have, in cases, bradycardia and hypotension. Typically, with beta blockers, you see change in mental status, and typically with calcium channel blockers, you see hyperglycemia. The things you have to think about are myocardial dysfunction, the bradycardia that's happening. Obviously, look at the interventions, and then I do want to give a very cautious tale about patients that we saw with amlodipine intoxication. They initially look fine, and then you might even sign off on them. And then once they start going bad, it's bad. So we lost, I think, a bunch of them to massive intoxications where in the initial few hours, they looked totally fine. And then we could not do enough to keep them alive. So calcium channel blockers, when they start deteriorating, it can be rapidly fatal. Next slide. Okay, so this is a management algorithm that I took from this article. It's a good article if anybody wants to look at it. The authors synthesized a bunch of society's recommendations and put it in a nice table. So they recommend initially to give glucagon for beta blocker, calcium chloride for calcium channel blockers, start pressors, high dose insulin. It works better for calcium channel blocker, but you should also try it for beta blockers. And then go up on the insulin up to 10 units per kg per hour. And then think about lipid emulsion and pacing. Um, I know we typically would, maybe go up on pressors at that point, but it seems that the high dose insulin, of course, you do it with D10 or D20, whatever you need, seems to have a very good impact on those intoxications. Next slide. So obviously, if you give high dose insulin, you can get hypoglycemia and hypokalemia. There are some cases where they had to use balloon pumps and ECMO even. And then if a patient comes in with cardiac arrest, you just skip all over and just go to lipid emulsion and calcium chloride. Okay, next slide. All right, so the idea is to use the lipophilic qualities of this agent to reduce the impact of the substances. There are some animal studies and human case reports. There is no case series or there is no randomized control trial. There will never be randomized control trial. So we have to use what we have. It's been used successfully in calcium channel blockers, beta blockers, but also in cocaine, Haldol, antidepressants. Um, I use it frequently for the folks who have TCA intoxication and the organophosphates. Then you have the dose there. It can give you pancreatitis. If somebody's on dialysis or is in shock, is going to need dialysis, you have to be careful because it can screw up your filter. It actually can give you fat embolism because you actually are giving a ton of fat and can cause cardiac arrest. But if somebody's coming in with cardiac arrest and is suspected to have this kind of intoxication, that's actually on your management, that's the first thing you should do besides the ACLS, obviously. Okay, next slide. All right, so
Sebastian, can I make one point?
Yeah,
And
absolutely.
Jason, yeah, no, that was a really great review. Just for the fellows, for your boards, remember you alluded to it that the dihydropyridine calcium channel blockers like amlodipine at very high doses are no longer non-selective for the cardiovascular system. So you will get that myocardial depression, you will get that hypotension, you will get that bradycardia at very high doses. We just had a case around Christmas time at Inspira, where a woman took 900 milligrams of amlodipine. She took a full 90-day supply. She OD'd on. Plus, I think she took 600 milligrams of metoprolol. So it was very, very refractory. And I think another thing, you pointed out the algorithm very nicely. I think the right choice on the boards oftentimes is to jump to, specifically for beta blocker toxicity, to jump to glucagon. But at some of your smaller community centers, you may not have enough glucagon to give one dose, let alone put them on a glucagon infusion. So you really have to think about your stepwise approach past glucagon, specifically for beta blocker toxicity, because you may not have enough to support the patient if the half-life of what they took was much longer than your glucagon supply.
That's a fantastic point, Jason. Yeah, these intoxications are very tricky, very, very tricky. Okay, so Jason, you pick which fellow you want to read this question.
Who's in the room right now? I saw Hirsch, and who else is in the room?
We have Paul Cantercat. We have Rick.
Oh, you don't have to say any more than that. Paul, you're up.
34-year-old presented BD after found by police wandering on streets, agitated, belligerent, confused. Blood pressure 220 over 135, heart rate 138, respiratory rate 28, pupils equal and dilated. EKG shows ST depression diffusely. CK 85,000. Troponin is pending. What's the best treatment in addition to aspirin?
Paul?
So this seems like.
So what do you think? So if you wanted to qualify what is the patient having, or you want to make a bet, if you're a betting man, are you a betting man, Paul?
Of course.
Of course,
Just that
great.
he takes clonidine and has not been taking his clonidine and has reflex tachycardia and reflex hypertension. The same.
Are you sure, or could it be something else?
I'm not sure how that would. I'm not sure.
Cocaine.
So you have a dude wandering on the streets
Okay. What is that? See depression.
who's having agitation, hypertension, tachycardia, ST depressions, and has rhabdomyolysis.
Okay, yeah, so cocaine is people who die.
So it probably took some sort of sympathomimetic, probably cocaine, especially in Camden. So what would you do for that patient who's having ST depressions and tachycardia in the setting of possible ingestion?
Doing beta blockade.
Everybody agrees with this assessment?
No.
I would not do beta blockade in an acute intoxication.
Okay, who's that? That's Lindsay?
Yeah, this is Lindsay. So the first line in this case would initially be usually benzos, but the second best answer then would be anything that's not a beta blocker.
Yes,
So
and I did not, and God give you benzos for a reason.
So then I would pick nitroglycerin of the ones that are available.
Okay, so next slide. Yep. So that is the actual answer that I think is the best answer here. So let's move forward. Next slide. Okay, so cocaine can cause a bunch of things, including arrhythmias, tachycardia, VFib, hypertension, dissection, and acute coronary syndromes. Next slide. When you have acute coronary syndrome with cocaine intoxication, the recommendation to do aspirin, like Lindsay said, benzos, but then you go to nitroglycerin, calcium channel blockers, and reperfusion sometimes. Even though it may be just a spasm, there is a hypercoagulable state, and in certain cases you might have to. Beta blocker use is controversial. Most people recommend not using it. Now, you will always find a case of somebody who used it and nobody died, but most people and most societies would say to not use beta blockers, and because you have other options, right? So you have benzos, you have nitroglycerin, calcium channel blockers that you can use.
Sebastian, can you hear me? It's Phil.
Oh, hi, Dr. D.
So I appreciate the acknowledgement on the Ipecac. First, I put this unopposed alpha concern with giving a beta blocker and producing paradoxical hypertension. I put that in the same basket as I do IV Haldol and DTAC and nitroglycerin and cyanide toxicity. I think that somebody came up with the possibility that these occur, and it's made people shy away from using them. I have an interesting history because I was treating cocaine overdoses with severe hypertension at the county hospital in Houston in the mid-'80s before someone raised the possibility of unopposed alpha. And we used a ton of beta blockers in these patients, and we never saw any unopposed alpha paradoxical hypertension in these people. But having said that, I would probably hesitate to use it now. But if I felt like I didn't have any other really good option, I certainly would use it because, I've done it so many times and never seen a problem.
Yeah, and Dr. D, thank you so much. This is actually the same exact recommendation that the societies would say, that if you used everything else and you have to use it, then sure. But as a first line, they don't recommend to use it right away.
Yeah, and the animal studies show how well benzodiazepines work to still the catecholamine storm.
Right.
That's certainly the go-to.
Right. And you didn't think I would remember that Ipecac thing, right?
No, worthwhile.
I missed it. What was the Ipecac?
So when I was an intern, Dr. D was giving us a lecture on intoxication, and I think his first line was, "Guys, Ipecac is dead." It was a sentence that I remember until now.
Well, so another plug for from a board standpoint, both the crit care boards and the neurocritical care boards. I've seen questions around Ipecac syrup. Ipecac syrup can cause acute myopathy. It's like myotoxic to the Z band of like the sarcomere. So just remember Ipecac and myopathy for people who take a bunch of Ipecac at home. It's bad news. I agree with you.
Yeah.
When I was running the county emergency department in Houston, we had a protocol that everybody that came in with a significant overdose got Ipecac, and if their level of consciousness prevented Ipecac, we intubated them and put in the old EWAL tube, which is a huge gastric tube, and we lavaged them. And that was just, you didn't even think about it, you just did it.
Wow. All right. Thank you, Dr. D. Thank you, Jason, for those points. Let's go to the next slide, please. So cocaine can cause a lot of things in the brain, including seizure, intracranial bleeds, intraventricular bleeds, and obviously ischemic strokes. Next slide. Okay, so the other ones, you all know them, pulmonary edema, bronchospasm, renal failure, rhabdo. Now, here's an interesting point that I think all the fellows should listen to. When somebody's hyperthermic because of a sympathomimetic, the issue is not a hypothalamic set point problem, and giving Tylenol or salicylate will not change the temperature. So treating hyperthermia with Tylenol here will not help because it's a sympathomimetic problem. So you need to use your benzos and then do cooling devices. You can do other modalities, but the Tylenol will not help. Also, we have to be aware of contaminants. A few years ago, I think 10 years ago, we had a bunch of patients who took levamisole with cocaine, and we saw a bunch of vasculitis. We also saw, I think in 2008, it was laced with clenbuterol. If you mix it with fentanyl, it can mask the cocaine. So one gives you the high, one gives you the low. If you take it with alcohol, it metabolizes into something called cocaethylene, which is less potent, but actually lasts much longer. So you get those 36, 48 hours of effect. Next slide. All right, so gastric decontamination, like we said, not helpful. You can use Precedex or Haldol, supportive care, and anticipate and treat the specific complications. Next slide. Okay. So Jason, who do you want to have read that? Jason?
Sorry, the unmuting button was not working. Lindsay has such a lovely voice while
She
giving
does.
insight
She does.
into cocaine. Lindsay.
Okay. So 24-year-old man is admitted to the ICU for seizures, hyperthermia, tachycardia, and agitation. Drug use is suspected, but the urine tox is negative for PCP, cocaine, amphetamines, and antidepressants. Which of the following is the most likely toxin? Ketamine, LSD, mephedrone, or GHB. So,
And by the way, folks, I'm studying for my research for the boards, and I saw in the question bank like 3 variations of this specific question. Something like that. You have somebody who's coming in with seizures, agitation, and the drug screen is negative, and then they ask you what's the next best thing that they took.
yeah, so ketamine wouldn't show up. LSD also wouldn't show up. Methadone, less familiar with, but also would likely not show up. And then GHB is not consistent with this toxidrome. So I would go with ketamine or LSD. So
Okay, so next slide.
methadone.
Okay, so let's go to next slide. So it's actually the bath salts. So
That's why I didn't know what they were called. That's a good one.
yeah.
I know them by the bath salts names.
Right. So the LSD would give you a hallucination, paranoia, but typically would not give you the adrenergic effect. So you think of bath salts when you have somebody who has sympathomimetic effects with the hallucination and paranoia. So this can last days to weeks. Apparently, there are some cases where it lasted, more than a few weeks. And this is one of those where you say, okay, bath salts. It's actually very popular still, I think, in the Seattle area for some reason. And you do think about it when you have this combination of agitation, sympathomimetic, and the hallucination with the negative tox screen. Next slide.
Sebastian, how do you take it?
What?
Is it like a cocaine? Are they melting it on a spoon? How is it?
Yeah, so the rumor is that they do the same thing that they do with cocaine. They either melt it on the spoon. I don't think they inject it. I think it's mainly the inhalation and the melting on the spoon.
Oh, quick point for those for the bath salts, for the synthetic cannabinoids. They can cause really profound vasopressor refractory vasoplegia. So it's sort of like you see this with patients who also take like very, very high doses of cocaine, and they kind of like wash out all of their ability to maintain their vascular tone. You'll see these patients come in and be very vasoplegic and end up being on very high doses of vasopressors for support. And then as this washes out, it gets better over time. We had a case that I worked with Tox on last year, and they were very, very vasoplegic. And this has come up, the vasoplegia has come up on the SEEK questions in the past.
So yes, thank you, Jason. And typically, the K2 and spice, which are the synthetic cannabinoid, would give you the same type of thing, which is the hyperthermia, and then the sympathomimetic with the hallucinations. And it's very difficult to say, they for sure have taken K2 or spice or bath salts, but historically, I would say bath salts were more popular on the East Coast 10 years ago, 15 years ago. Right now, it seems that K2 and spice are more popular in our area. So that's one of those things that doesn't show up on the touch screen. Next slide. All right. So again, you give Haldol and benzodiazepine. Same thing for the hyperthermia. It does not involve a hypothalamic issue, so you don't use Tylenol or salicylates. You need to stop the heat muscle activity. So if you need to intubate and paralyze, go ahead, but do not use succinylcholine. Cool them as much as you can. That would help with the rhabdo, that would help with the seizure, would help with the hyperthermia, would help with pretty much everything. So supportive treatment, intubation, sedation, paralysis without using succinylcholine. Any questions or comments regarding this synthetic cannabinoid? Okay, next slide. Jason, who do you want to have next?
Poor Rip in the background, still recovering from quite the week on green. Rip, this one's all yours, bud.
All right. 21-year-old female presents after a suicide attempt. She has a history of depression, is on many medications. On admission, she is obtunded and is promptly intubated. Her vital signs are 98/47, pulse ox 93. Her lab work is pending. You obtain this ECG. What is the next step in management? Looks like YQR is C.
So obviously we're baiting you towards thinking about something, right? She has a history of depression. She probably is on medications that treat depression, right? And she had a suicide attempt. So the assumption is that she probably took some of the medications for depression to try to commit suicide.
C. Sorry.
Yeah, we think she took TCAs. There's an R prime in, I think it's lead ABR. So we're going to go with sodium bicarbonate.
Okay, so next slide. Good job. All right, next slide.
Good.
All right, so as you guys said, it's probably a TCA poisoning. It inhibits the fast sodium channels on the heart. It can cause, all sorts of symptoms related to anticholinergic signs, also hallucinations, confusion. Similar to the bad calcium channel blocker intoxication, TCA overdose is really bad. And once it starts going south, it goes really south really quick. The recommendation is once your QRS is 100 or greater, you should promptly give treatment for that with probably sodium bicarb. There is some controversy whether sodium bicarb versus 3% saline versus just a lot of salt. But if you give 150 milliequivalent of sodium bicarb, you're still doing standard of care. And the longer the QRS is, the higher the likelihood of seizure and VTAC and VFib is. Next slide. So you need to alkalinize the urine as much as possible, and you get the blood to about 7.5, 7.55. So you just give 2-3 amps of bicarb, look at the QRS, and then just start the bicarb drip. There are some recommendations that if this doesn't work, you go ahead and give hypertonic saline. You can also do a lipid emulsion. But these are we have less experience with those. I do have to confess that recently treated a TCA overdose at Malika Hill, and it was so bad that I skipped. I just went from bicarb lipid emulsion, and it went fine. So maybe a role earlier in the management algorithm, because I get very nervous with TCA and the TCA overdoses. Next slide. All right, who wants this one? Jason.
I'll do it.
This one's gonna. Oh, okay.
I'll do it. I haven't done one. It's Mike Post. 65-year-old female, history of hypertension, non-insulin dependent diabetes, on glyceride, depression. Was found unresponsive at home. In the ED, she's hypoglycemic. POC was 20. Blood pressure 98/58. Heart rate 105. Her chemistry is unremarkable. In addition to IV glucose, what other treatment modality would you give to the patient? Whoa. That's a good question. Propanolol, parathion, I don't know what that is exactly. Lipid emulsion or octreotide. I feel like it's octreotide. but I'm not sure at all. That's a guess.
Well, your feeling is good, my friend. Next slide. Okay, next slide. All right. So, by the way, we need to have a guy named Daniel Gorman to do the next slide. He's answering on the chat with a lot of good answers. So I want this guy to answer the next question. Okay. So, yep, Dan, you're up. So drug that potentiates the action of the sulfa drugs are the quinolones, azoles, alcohol, chlorpropamide. If somebody's taking it, can take 72 hours. You treat with octreotide 150 to 100 every 6 hours. And after you achieve euglycemia, you still have to monitor for 24 hours. If they have hypoglycemia again, you restart another cycle of 24 hours. So, and you don't stop until you finish 24 hours, and then you monitor. And if you have it again, guess what? You do it again another 24 hours. So that's how it goes. Any questions? Okay, next slide. All right, Dr. Gorman, the famous Dr. Gorman.
All right, 55-year-old male presents to the ED with obtubation and hypotension. He has suicide attempts in the past with TCA and SSRIs. He also has a history of hypertension and bipolar disorder. He takes lithium as well as amlodipine. He works as a janitor on night shift at the hospital. BP 75/43, heart rate 50, sodium 144. K is 3.8, chloride 108, bicarb 26, glucose 86, BUN 9, creatinine 1.2, serum osmolality 240 milliosmoles per kg. What is the most likely intoxication? So he's hypotension, bradycardic.
By the way, this should not really be 240. Just forget about the osmolarity for now. This is a typo.
Oh, okay.
Sorry.
So in terms of his vitals, he's obtunded, he's hypotensive. And so what's the osmolality then? Just ignore that?
Yeah.
Just
I think he
ignore.
doesn't want us to calculate it because it got messed up.
Yeah, I mean, if you do the calculation just with the sodium, you're already at 288, right? So you cannot have an osmolarity measured that's lower than that.
Okay.
Lithium.
I mean, look, if you want, use 340. Would that be?
Oh, okay.
Would that help you? Use 340 as the osmolarity.
Yeah, so if it's 340, then you have an osmolar gap and not an anion gap.
Correct.
Which would tip you towards isopropyl alcohol. And that would also be obtunded and hypotensive. So I like that answer then.
Perfect. Perfect. Next slide. Great answer. So the osmolar gap is very useful for intoxications. It identifies the substances that are not in the blood, and it has to be somewhere between -10 to +10. There's some people that say, the more you age, the higher it has to be. But if you get values in 20, 30, you have a problem. You have something there that's not accounted for that is impacting your osmolarity. Next slide. So the causes of an elevated osmolar gap, with an anion gap, you have all your regular alcohols, methanol, ethylene glycol, and propylene glycol. If you have small elevations of gap, small elevations of the osmolar gap, that is, you can have that if you have very bad lactic acidosis, very bad ketoacidosis, and bad renal failure. Now, the lactic acidosis, we're talking about the 15 to 20 range, but nothing in the 6 to 10 range. With normal anion gap, you typically think about something like ethanol, isopropyl alcohol, mannitol, sorbitol. I put ethanol twice because that's probably what we see the most often. Next slide. So this is a slide for people who don't like to take Ambien to sleep and want to have fun. So this is metabolism or the different alcohols. Um, ethylene glycol, you end up with oxalate in the urine. Whenever they say, okay, you have to examine the oxalate in the urine, it's very non-specific. It's very hard to examine, and it doesn't mean much, but it's a favorite thing on the board. So if it's on the board, it's the right answer. If it's not on the board, it's probably the wrong answer. Uh, propylene alcohol, glycol ends up with lactic acid. Diethylene glycol is something you find in the brake, the brake fluid. I don't know why somebody would take that, but that's what it is. Next slide. So this is the very interesting slide, guys. So as you start with all of these ingestions, over time the osmolar gap goes down, and as the osmolar gap goes down, the anion gap increases, and that's because you have the substance that used to be, whole in the beginning, giving you the gap. As it's metabolized, it ends up becoming acid and whatnot, and then you get more of a gap. So you can have somebody who took ethylene glycol 24 hours ago, who's coming in with no osmolar gap, just anion gap, and that's because everything is metabolized. And then the course of these changes is impacted by the fact that you're taking or not uh, alcohol. So I remember the story that Sergio used to tell us, where there were a bunch of people that went out to have a party, took a bunch of alcohol that a friend had prepared, methanol. One of the friends felt tired and then went to sleep. The others went out to the bar and continued on drinking regular alcohol. He woke up blind and they woke up fine. That's because the alcohol was protecting him and was mitigating the effects of methanol. Next slide. So this is, I'm not going to go through all of this, but this is giving you the specifics of how much impact you have with ethylene glycol, methanol, and propylene glycol on the gap, and what are the different time to onset. You can see that methanol, if you take it with alcohol, you can have lab problems until 4 days, which is pretty substantial. So always beware of the alcohol impact on all your abnormalities. Next slide. So if you see, again, oxalate crystals, ethylene glycol, visual problems, methanol, you should in the modern medicine, you should use fomepizole. There are still some protocols with alcohol that people can use. I think 15 years ago, we used to be able to prescribe Bud Light for our trauma patients. I don't think we can anymore. The level where we say you have to hemodialyze would be more than 50, or with refractory acidosis.
Dr. Rachoin, I have a question. How long does it take for that level to come back?
That's a very good question. If you suspect it, you give fomepizole.
So
By the time,
you're saying you won't have time to view
Nope.
the level and initiate fomepizole or dialysis at that point. If you have high index of clinical suspicion, just go down that path.
Yeah. So I would say if you're lucky, it comes back within 48 hours. If you're lucky, that means it's drawn during business hours, and the courier doesn't mess it up, sends it right away to the reference lab. The reference lab calls you back right away. That's 24 to 48 hours. You're super lucky. Typically, you wait for it, and then you call the labs like, oh yeah, we don't know how to process it. We just left it here. So if you suspect it, just do it. And a very good question, Hirsch. Next slide. Okay, so isopropyl alcohol, rubbing alcohol, obviously. You see an increased osmolar gap without an anion gap. You can still have some ketonuria, and you're obtunded and bradycardic. And treatment is here just supportive. You should not use fomepizole at this point, nor you should use dialysis. You're going to do okay with just fluids and supportive care. Next slide. All right. So this is an interesting one. Lithium overdose. It can be acute or chronic, or acute on chronic, right? A lot of patients get in trouble when they start ACE inhibitors or NSAIDs because that increases the level. In acute setting, it can cause, neurologic problems, metastasis change, but these symptoms usually happen late in the course because they have to be absorbed in the CNS. It's an intracellular drug. And by the time you see mental status change due solely to lithium, you have a problem. That means that you have enough in your body to have, and you took it for quite a long time, and it's been in your system. So I would treat that very differently than somebody who's not having mental status change. In acute intoxication, you can see a null or a negative anion gap, which is very interesting. If you see a negative anion gap, they want you to pick lithium. The other one that could give that is bromide, and I don't see many bromide intoxication in the US. So if a negative anion gap, they want you to pick lithium. If the level is very high or symptomatic, you probably should dialyze the patients. Other than that, it's the regular support of ABCs and hydration. Next slide. So I left a little bit of minutes for questions or comments from attendings in the room. Jason.
Yeah, no, that was an excellent review. We'll have to. I'm going to bring you back for the board review in May. That was a fantastic toxicology review. I think you guys will see all of these things, both in person and on your boards. Sebastian, putting your nephrology hat on, I've gotten into this sort of debate, at some of the outside institutions. One, I can remember a patient very much had a change in mental status, had an AKI, and was, tachycardic with a presumed lithium overdose, elderly. They sort of talk about, even in the elderly, you could have a normal lithium level and have lithium toxicity. In chronic
Absolutely.
patients, maybe 2.5 is too high and not
Yep.
5. What do
Yep.
you think?
So I would say, Jason, if you talk with a lot of folks that have done this for a while and have more gray hair than me, when you get mental status change from lithium, you probably should dialyze and should dialyze several times. And it all depends on what's your patient. If the patient is old and frail and could die, I would dialyze him probably right away.
That's a great point.
That's my honest opinion.
Great. That's great.
So,
any other questions?
So I had a question about cocaine. Going back to what Dr. Dellinger was saying, that in the past they used to use beta blockers. Are there any studies today that show treatment of cocaine using a similar mechanism of the way we treat, I forgot the name, but like phenoxybenzamine and beta blocker? Pheochromocytoma, like treating cocaine with the same mechanism of pheochromocytoma.
So I personally am not aware of any people that specifically look at that. The main thing you have to remember is whenever you're gonna do any kind of studies like this, you have to compare it with the standard of care, and you have to have failed standard of care before you do that, because otherwise you're doing a disservice to the patient if you're withholding a valuable life-saving medication, right? So if you say, look, I'm going to randomize you to benzos and nitrates and aspirin, or I'm going to randomize you to just phenoxybenzamine, I don't think anybody would do the study. It's just too risky. That's my opinion. I'm not aware of any human studies on this. It could be some animal studies, but I'm not aware of any human studies. Okay.
Yeah, neither am I, and I think that sort of keeping calcium channel blockers and benzodiazepines as your first line should probably make the most sense. Yeah, I don't know. It's a good thought, pharmacologically. I just don't know how. Yeah, again, you could do that, and how you could control for that. Another interesting cocaine toxicity question that they could phrase it a different way is for a patient who presents with either hemiplegia, aphasia, has bilateral thunderclap headache. Does anybody know what that is?
That carotid dissection.
It's a good thought, but you have a negative CT, negative CTA, and even more importantly, they'll phrase the question with a negative LP for xanthochromia, because clinically you're going to think that this patient has a subarachnoid hemorrhage.
Other things on my radar would be cerebral venous thrombosis or carotid artery dissection.
It's a good thought too. But this is reversible vasoconstrictive syndrome, where you have this, cerebral reversible vasoconstrictive episode related to cocaine toxicity. You can also see it sometimes in SSRIs, but the classic question is either using pseudoephedrine or cocaine, and you treat with calcium channel blockers. So just remember that.
So I would throw another one there. They would also sometimes bring you a patient that is a renal transplant, that takes tacrolimus, and that has this symptom, and they want you to stop the tacrolimus. That can give you that as well. I've actually seen that when I was in my old life, pressed due to that.
That's an excellent review. Anybody have any questions?